countries, 187, I believe, or more. So far, almost 300,000 deaths. Fortunately, many people have recovered, but not everybody has recovered. The typical symptoms caused by this virus classically includes flu-like symptoms, including a fever, a cough described as a dry cough, fatigue, shortness of breath, loss of sense of taste and smell. Many patients, in fact, the overwhelming majority of cases, may not even be aware that they're affected or infected and are asymptomatic or very mild disorders. We know that it affects patients differentially, men more than women, older more than younger, and patients with comorbidities. In its worst scenario, it can lead to an acute respiratory distress syndrome leading to multi-organ failure, septic shock, thrombosis, widespread thrombosis, including intracranial thrombosis, strokes, pulmonary embolism, and unfortunately, ultimately can lead to death. We know that the exposure from time of exposure to the onset of disease is variable. It can be somewhere in the range of 1, 2, or 3, 4, 5 days to as long as maybe 14 days, 2 weeks, which of course is the main reason why when you go into quarantine, a patient goes into quarantine, we recommend a period of at least 2 weeks. We know since late December that it is spread by person to person, close contact, typically droplet spread, but also aerosols, coughing, sneezing, even talking can lead to transmission of the virus out of the nasal passages, the oropharynx, and if you touch your face or a contaminated surface and then touch one's face, this can lead to virus transmission, and it's extraordinarily contagious. Rapid way of diagnosing by RT-PCR with a nasopharyngeal or oropharyngeal swab can obtain the diagnosis very, very quickly. We know that as much as possible, it is better to prevent this disease than to try and cure the disease. In fact, there is currently no known cure. There are treatments that are available, but there's no known definitive cure as of now. As we all know, scientists are working very hard on vaccines and therapeutics, but as of now, it is mostly supportive care. So in terms of preventing, what advice can we give to patients? Stay at home as much as possible to reduce the risk of being exposed. Avoid crowds, limiting close contact with other people, and observing the rules of social distancing of at least 6 feet to reduce the risk. Non-essential travel, particularly in dense commuter travel like subways, trains, airplanes, and that sort of thing, congested airports, bus stops, train stations, this kind of thing is to be avoided. Frequent hand washing with soap destroys the virus, we know that. And patients should be advised, as well as health caregivers, nurses, and so on, doctors, wash your hands for at least 20 seconds, certainly after patient contact or being in a patient care area, before eating or drinking, after using the bathroom, restrooms, or blowing one's nose, coughing, or sneezing. These are known ways of reducing transmission. And it's very important that we all observe this very, very strictly. In cases where there is no ready access to soap and water in areas that are limited in terms of infrastructure, then alcohol-based sanitizers with at least 60% alcohol is recommended. Cloth masks, surgical masks, even bandanas to cover the nose and mouth, very important to limit transmission, particularly when coughing or sneezing, or using a tissue or covering one's face or nose with your flexed elbow and throw the tissues in the trash, because virus can live on surfaces, on non-porous surfaces for even up to 3 days, it's been seen. And so if you don't properly destroy fomites, they can be sources of transmission. Now, let's talk more specifically about the issue of pituitary medicine, pituitary tumors, pituitary surgery. As with all things in this particular field, it is very important for us as neurosurgeons to be aware of the fact that what we're dealing with pituitary medicine and pituitary surgery involves and is best taken care of with multidisciplinary inputs. What do I mean by multidisciplinary inputs? Well, it is not just the neurosurgeon's judgment and input that's important for the care of these patients. As you know, we have to collaborate with our colleagues in endocrinology, in neuro-ophthalmology, particularly when we're trying to make decisions about the timing of surgery. The neuro-ophthalmological input is extraordinarily important. Radiation oncology, when we're discussing alternatives to surgery, such as radiosurgery or fractionated radiotherapy, this is also important. Our colleagues in anesthesia, when we're talking about the risk of putting a patient with acromegaly to sleep or looking after patients in the immediate post-op period who need things like CPAP or respiratory care. In order to evaluate patients, obviously it is preferable if you see the patient, but during this time of pandemic spread with high prevalence, this is not recommended. And we have to limit contact even with the patients that we want to see by maximizing the use of telemedicine, video conferencing, Zoom, WebEx, Skype, and so forth. And you can assess a patient's condition with pituitary tumors quite reliably by looking at the medical records, the visual studies, the laboratory studies, the MRI, and then discussing with the patient by video teleconferences to make a decision. So we have been using telemedicine now for the past 6 or 7 weeks for our clinical evaluation and discussion, even in our multidisciplinary clinic. So we'll have the endocrinologist on the line, the neurosurgeon on the line, and so on and so on. We'll have all the medical records. We'll be able to share the screen with the patient so that we can look at the MRI scans together with the patient and the referring physicians and discuss and make a decision. For those patients that have been recently diagnosed with an infection, in other words, a pituitary tumor that has been diagnosed recently with a COVID infection, that patient needs an urgent telemedicine appointment. We know that pituitary tumors just in and of themselves per se do not affect the immune system. But the comorbidities and the associated medical problems with pituitary tumors can severely impact the immune system, can severely impact the risk of infection, can severely impact the course of disease with any infection, and in particular in COVID-19. So what kind of comorbidities am I talking about? Well, in the case of pituitary medicine and pituitary tumors, the key things that are causing problems with COVID-19 patients are exactly the very things that are very common in patients with pituitary disease. For example, in patients with Cushing's disease, in patients with acromegaly, there's a very high incidence of diabetes. in fact, virtually all those patients will have either pre-diabetes or will have frank diabetes mellitus. Second, hypertension. And we know hypertension is a significant risk factor for COVID-19. It severely impacts the course of the disease. And it's one of the things that can put the patient into the ICU. So we know that hypertension, diabetes are both significant risk factors and comorbidities in patients with both Cushing's disease and acromegaly with excess growth hormone secretion. Third, obesity. Obesity is a significant risk factor in COVID-19, and obesity is a significant comorbidity in Cushing's disease and in patients with hypopituitarism. Fourth, cerebrovascular and cardiovascular disease, major risk factor for COVID-19. Cerebrovascular disease and coronary artery disease, also significant comorbidities in Cushing's and acromegaly. So these comorbidities and medical associated problems have to be intensively diagnosed, intensively managed in patients with pituitary disease, tumors, and so forth, and facing the COVID-19 infection. Finally, hypopituitarism is very important comorbidity in patients with clinically non-functioning pituitary adenomas and in patients with things like craniopharyngiomas and other anterior skull-based lesions that affect the pituitary stalk. And this also makes them significantly more vulnerable to fighting the COVID-19 infection. So for all these reasons, not just the surgery in pituitary, we're going to get to that too, but the actual medical management of the patient, the actual medical presentation of the patient is at significant, presents significant challenges and significant comorbidities in managing the COVID-19. Now let's take some specific examples. I'm going to start with adrenal insufficiency and Cushing's disease. So adrenal insufficiency and Cushing's disease are two ends of the same spectrum. Adrenal insufficiency, patients with hypopituitarism, secondary hypopituitarism, could present with secondary adrenal insufficiency from a lack of steroid production, which of course is a key factor in the response to infection and the response to illnesses and managing the response to patient stress. Cushing's disease, of course, is on the other side of the spectrum. Here we're dealing with an excess of cortisol. So adrenal insufficiency presents an increased risk of contracting the COVID-19 infection, and even after you contract it, for that patient, it presents a higher risk of complications. In fact, you can trigger adrenal crisis by being infected with the COVID-19 in a patient with existing secondary hypocortisolemia. Therefore, it's important for these patients during this period of high prevalence, if you know you've already treated a patient either for Cushing's and they're in remission, or they've got hypopituitarism, either from a Rathke's or craniopharyngioma or previous surgery or previous radiosurgery, and have secondary adrenal insufficiency, the patient should be carefully counseled and instructed to continue taking medications as prescribed. We have to make sure that they have adequate supplies of both the oral as well as the injectable form of steroid, because if they're sick and have nausea, vomiting, or poor absorption, they need to be able to get those steroids in a reliable fashion via the injectable route. If they become ill with COVID-19, they have to increase the dose of hydrocortisone. Typically, we recommend they double the dose of the hydrocortisone or the prednisone or the dexamethasone to be able to manage that condition. If the patient is clear signs of infection with fever, cough, shortness of breath, that patient needs to immediately call the hotline or go to the hospital, and they may need to be actually admitted into the hospital. Patients with Cushing's obviously present a different end of the spectrum with immune suppression. They're already at the high risk of infections. And in cases of moderate to severe Cushing's, those patients will need urgent attention and medical treatment pending definitive surgical treatment. Now, in going further along with Cushing's, as you know, the diagnosis of Cushing's frequently will rest on obtaining at least two consecutive salivary midnight cortisols. Why do we get this? We get this because we want to establish the lack of diurnal variation with salivary cortisols being elevated in Cushing's at midnight as opposed to the normal patient who does not have Cushing's. However, during this pandemic, it has been cautioned that obtaining salivary cortisol can cause or lead to viral contamination, which can cause problems with the laboratory staff processing these specimens. And so it's been advised that we hold off on obtaining salivary cortisols during this period of time, and we wait until we can get to a safe point when we can reliably obtain salivary cortisols without risking the infection of laboratory staff. Also, during the workup for Cushing's, normally we will reserve obtaining a CT scan of the thorax and abdomen until the workup has suggested extra pituitary Cushing's. But in this scenario, during this pandemic, we want to obtain the CT scan earlier on in the diagnostic evaluation, because if the patient has adrenal or small cell lung cancer, that patient obviously needs to be expedited to go to surgery for cancer. In general, we're advising that patients with Cushing's, unless they have no other option, be deferred in terms of surgery during this pandemic. And if they require control of hypercortisolism, that patients be put on steroidogenesis inhibitors to inhibit the synthesis of cortisol during this period of time for the next few months until we are able to resume elective schedules in the hospital. And this obviously needs to be done in conjunction with our endocrine colleagues to make sure that we have a good response to the medical treatment whilst we are waiting to put the patient back on the surgical schedule. Patients who have severe Cushing's should also be treated for the kinds of infections that they are susceptible from immune suppression. And a good example is pneumocystis. And this is particularly important because the coronavirus, COVID-19, presents with typically respiratory problems. So sometimes it can be difficult to distinguish between a patient who has a flu-like pneumonia from somebody with true COVID. And it may be difficult to distinguish the two. Therefore, it's important to eliminate things that can mimic the COVID-19 infection in patients with Cushing's. Now, if the patient with Cushing's has severe disease and you have tried putting the patient on steroid inhibitors, and despite putting the patient on steroid inhibitors, even after several weeks of treatment, the patient continues to run very, very high levels of cortisol, high levels of blood sugar, remains hypertensive, or maybe they have side effects of the medical treatment, then I think you have to decide to go on to surgery if the patient tests negative and if you have the appropriate amount of personal protective equipment to execute the surgery and then go ahead with surgery in that type of situation. Obviously, you want to do this in circumstances with the best experienced surgeon you have at the time, because this is maybe the only good chance of getting a surgical remission in the patient. So let's leave Cushing's and consider the other groups of pituitary tumors during this pandemic and how we should be managing prolactinomas. How should we manage growth hormone tumors and non-functional tumors? Our current policy right now is that in patients with mild acromegaly, in other words, measuring their growth hormone, measuring the IGF-1 levels, the disease is mild. Symptoms are mild. They don't have significant diabetes that's difficult to control. They don't have hypertension that's difficult to control. They don't have significant obstructive sleep apnea that's difficult to control. And they don't have visual compromise. In those cases, it is safe to defer further evaluation and management, surgical management of those cases. Even the medical management can wait in those cases for the next several months or at least several weeks until things die down, and then take up the evaluation and management thereafter. There will be very little downside and very little negative consequences of a patient with mild acromegaly waiting a few months. If the patient has severe acromegaly, like what we just talked about, but has no visual deterioration, no visual compromise, no bitemporal hemianopsia, that patient should be put on medication, somatostatin receptor therapy, or growth hormone receptor blocker with pegvisomab, and that therapy should be enough to bring down both growth hormone and IGF-1 levels with medical improvement, since there's no rush to decompress the visual pathways in that patient. Now, obviously, if the patient does have visual deterioration, that changes the equation, and that patient will obviously need to be considered for surgery. How about the prolactinomas? Well, I think, as you know, even before the COVID pandemic, the first line of treatment for the vast majority of prolactinomas is medical management with dopamine agonist treatments. So, and that remains true right now. So a patient with a symptomatic microprolactinoma or even a macroprolactinoma without visual compromise, I think it's quite safe in the microprolactinoma even to wait further evaluation, particularly if they're not worried about significant symptoms like breast milk discharge or fertility or absence of periods, that sort of thing. You could wait to see them in the clinic or to do their telemedicine consult. Obviously, patients who have symptoms or have large tumors, they should be put on dopamine agonist treatments, just as those patients who have visual field cuts. In the cases of the non-functional tumors, what we're doing right now is if the patient has been evaluated, there's no mass effect, or the visual fields are very mildly disturbed, that patient can be safely monitored with repeat visual fields and symptom observation at monthly intervals, and only if vision deteriorates will surgery be warranted. If the patient has associated hypopituitarism, that can be evaluated with laboratory studies, and then the patient can be managed effectively with hormone supplementation. For patients who are following the clinic who have had surgery and are in remission, we follow them on telemedicine with video conferences or by telephone. We obtain the laboratory studies and we call the patient with the results. Similarly, patients who are well controlled on medical therapy, again, those can be safely followed by telemedicine. They don't need to be seen in the office. For patients who are considering for radiosurgery or SRT, we postpone that and we tell them to come back in a few months for a reevaluation. We minimize the number of MRI requests we're doing just to reduce the overall risk of transmission and the overall stress on the medical resources, and we just monitor the patient clinically. let's move on to the conditions of managing diabetes insipidus and hyponatremia. Patients with fever, tachypnea, and are sick from COVID-19, have impaired ability for fluid intake, need obviously very careful monitoring for sodium, particularly in this time of the pandemic, especially since blood testing may be minimal or limited because of the stress to the system. And bear in mind that the major complication in patients with DI who are on DDAVP, who can't be followed easily with laboratory studies during this time, is the risk of hyponatremia. So if the patient can't get laboratory studies because the laboratories are stretched thin, then it's better to delay replacement and allow for diuresis because to prevent things like hyponatremia. In patients who have just mild COVID-19, are able to drink, are alert, and have diabetes insipidus already, then they can be managed just well with oral desmopressin. Because in those patients, you don't want to use intranasal because typically, because of COVID infection, they'll have congestion of the nasal passages, and that's where the nasal reservoir for the virus is. So we avoid giving them intranasal DDAVP, and we use oral desmopressin. If it's a severe case of COVID and they've got diabetes insipidus, they should be managed with intravenous desmopressin in that situation. We do not want a patient with COVID and diabetes insipidus to get dehydrated because of the association with COVID-19 and hypercoagulability and the risk of thrombosis, venous thrombosis in particular, and of course that leads to pulmonary embolism. And we've already seen cases of strokes, intracranial strokes, from thrombosis of intracranial vasculature. So it's advised that patients with DI and COVID infection be put on prophylactic subcutaneous heparin. Now, most surgeons who do and are very active in pituitary surgery during this period of time have accumulated a backlog of cases, which is the same thing in my department, because most offices are still not at full capacity. So patients who are waiting get put on the waiting list, and we advise the patient that they should stay in close touch with us, advise us if there are any changes in their medical condition, any changes in vision. If we're being monitored by for vision, they get regular scheduled feels. And if they're being managed medically, obviously close contact with the endocrinologist to make sure that they're actually responding well to the medical therapy whilst awaiting surgery. I think we must advise patients that overall the natural history of pituitary adenomas is good. These are not rapidly progressive tumors, so waiting a few months is not going to materially, in the majority of cases, cause significant negative complications. And most patients are stressed out already, so it is our job as neurosurgeons to be able to tell the patients who are worried that for the most part, because of the known natural history of adenomas, that they can wait with appropriate surveillance. And those patients who do wait, we need to let them know, and we need to counsel them properly that there is temporary medical treatment in the cases of Cushing's, in the cases of acromegaly, and in the cases of prolactinomas, and all they have to do is to make sure that we get them into the right hands and appropriate medical therapy whilst awaiting surgery. Obviously, they're kept on the list until we're able to operate. Obviously, there's the special case of pituitary apoplexy. As you know, this occurs in about 9 to 10% of patients across the board. Classic symptoms. And the majority of patients with apoplexy do not need emergent intervention, but some do, with patients who present obviously with dense bitemporal hemianopsia, severe loss of vision, and patients with complete right third nerve palsy, left third nerve palsy, or bilateral third nerve palsy. Obviously, those need to be immediately operated on for decompression. In the hospital, most hospitals, we know, including mine, and I'm sure in your hospitals as well, you need to advise the patients, if we're going to be brought into hospitals, that they will be likely in a hospital with COVID-19 patients. Some hospitals will have, even in the same unit, COVID positive and COVID negative patients because, there's just no space and you have to put the patient somewhere. Fortunately, in our hospital, we haven't had that problem. Although limited resources everywhere with anesthesia, radiology, and ICU beds is a big issue. Most hospitals require testing. Not all do. Some hospitals only require testing for certain categories of patients, and not all. Many hospitals will have limited traffic, usually will not allow visitors, family members, even if the patient is undergoing surgery or is in the intensive care unit. So we need to let the patients know that they may not be allowed to come into the hospital with the patient if they're going to undergo surgery. And we also advise all our patients that even if we put them on the surgical list, given the difficulties of predicting the needs of individual patients, the case may be cancelled at short notice or no notice. Some of the things also that hospitals have put into place, obviously, is the overall reduction in elective activities. This is gently picking back up in some places right now. Most hospitals have devised ways of minimizing spread from physicians to patients and patients to patients by strict infection control measures and limiting transmission, encouraging the use of hand washing, sanitizers, and masks, and so forth. All patients and visitors into the hospital obviously need to be screened appropriately for symptoms and contact and travel history. Most places have specific teams, specific nursing teams, specific physician teams that look after COVID-19 patients. But some patients and some physicians are being redeployed to patient floors where they have no previous experience, but there's a strong need of personnel manpower. PPE has been in short supply in many areas, and it may be the same thing in many countries across the world. It certainly has been a problem at certain times in the United States here, in some hospitals, in many hospitals, although that supply crunch is slowly getting much better and so forth. And in our hospital, we require patients to wear surgical masks during transport, and all people coming into the hospital must have a surgical mask on. Let's go into specifics about the endonasal surgical procedure. Given the fact that there's a significant backlog, a lot of neurosurgeons and hospitals have given to looking at triage mechanisms, and different hospitals have implemented different triage algorithms. Some of the ones that are important to pituitary I've discussed already. But these triage decisions need to be consistently updated because the situation is rather fluid. And whilst, as I said, the patient is waiting, the patients must keep a diary of symptoms. And if any patient notices worsening of symptoms, they should obviously let the physicians know so that the patient can be moved up on the list of backlog of patients. We only advise and we only perform surgeries that cannot be delayed because of the reasons we discussed just yet. And if alternatives to surgery are available, medical alternatives, then we err on the side of choosing the medical alternative, monitoring the situation until we can justify the surgical intervention. Of all the procedures in neurosurgery, the endonasal transsphenoidal operation for skull-based tumors is unquestionably the highest risk procedure. Why is that? Because that's where the virus lives, and that's where the viruses are spread from through the respiratory epithelium, the sinuses, the nasal passages, the nasopharynx and oropharynx. Our policy at this time is to, if we've made a decision to operate on a patient for the reasons we've talked about, that patient gets a COVID test and COVID antigen test, RT-PCR before surgery, 48 hours prior to surgery. Then the patient is told to go into quarantine so that they have no further contact with other people, so that they eliminate the risk of new transmission. If they're already in the hospital, obviously that's not an issue. If the patient tests positive after that test, then we have to reconsider, we will reconsider our decision to operate. If we can reconsider the operation and we can defer it until the patient is clear of infection, then we'll do that. But if the procedure is deemed to be critical, for example, critical visual loss would be a great example. Severe intractable Cushing's disease with no possibility of medical control, that would be another situation. Pituitary apoplexy, that's another situation. In that situation, then we are going to go ahead and operate with appropriate anesthesia preparation. Patient is intubated in a specific room, and other than that, where the surgery is going to be done with aerosolized protection. Patient's then brought into the operating room. The patient obviously is prepped in the usual manner for surgery, and we use all typical gowning procedures for the patient, sterile draping as we normally would. As surgeons, we use the appropriate PPE, which includes the N95 mask, we use goggles, and we use visors. If the N95 mask is poorly fitting, then we use PPAR equipment or CPAR equipment. If there are false negatives, as we know that they can be, we have to advise the surgical team that appropriate high-level PPE should be undertaken, even in negative cases, because of the potential risk of false negative. We will limit the use of micro debriders and drills within the nasal cavity. So if you can use kerosene rongeurs, if you can use other bone biters, if you can use other tissue biters, that is preferable to the high-speed drill and the micro debriders. All of these obviously produce a droplet aerosol, which is highly contagious. If the field or your face is contaminated, obviously that surgeon needs to immediately unscrub and leave the operative field, ungown, undress, to go clean, wash the face with soap and water. Same thing with if the gown is breached or the gloves are breached. I double glove, I double gown in addition to what I described to you. I use I use a chlorhexidine or betadine prep as normal. I haven't changed that preoperative preparation. There are some people who have used sticky drapes to cover the overall facial area to limit the chances that the drapes come off. I think that's fine. I don't myself personally use that. The other issue is in the post-operative care. Our ENT colleagues are not seeing patients for post-operative debridement and endoscopy because of the risk of transmission. And they're not recommending spray decongestants or spray anesthetics during the post-op clinical care, which means that patients potentially could have a higher incidence of adhesions, higher incidence of scabbing, higher incidence of nasal airway problems. We haven't been able to see that yet because we don't have enough follow-up, but that's one of the potential downsides of this, is that patients down the line, several months down the line, may show higher incidence of adhesions in the nasal passages because of the less attention to post surgical endoscopic examinations and care. Nasal pledgets are fine instead of the spray and the decongestants, and that is also a way to get around this. So with that, I will close and be happy to take any questions.